Good morning, Honorable Chairperson, faculties, and dear participants. I am very much honored to be here, and thanks to IPDI Foundation for inviting me for presenting my topics on the ECG in emergency decision making. Sir, there are some situations when the patient's condition is critical and ECG is the only tool to take the decision, and there is a question of life and death. We have faced such a situation, and I will describe, sorry sir for the interruption. So I am describing such a situation when the patient's condition is critical and ECG is the only tool to take the decision in such situation. I will give some examples. Case 1, this is a 30-year-old lady, attended at emergency, palpitation for 2 hours, blood pressure is 110/70, heart rate is 138 beats per minute. Now, what is the diagnosis? From the ECG, we can see the heart rate is 138, rhythm is irregular, no P wave, wide QRS, and LVV morphology. And obviously, we all know, in such situation, the differential diagnosis includes ventricular tachycardia, atrial fibrillation with bundle branch block, and pre-excited atrial fibrillation with WPW syndrome. These are the common differential diagnoses of some ECGs. And to take the diagnosis, this previous ECG helped a lot. Actually, this is the previous ECG, and we can see there is a short pair. This is actually not a classical ECG of the WPW, but we can see there is a short pair interval. You can see short pair interval, and there is a slight slurring of the initial part of the R wave, that is the delta wave, and possibly this is because of the pathway of the left lateral, what we found finally when we ablated the case. So this is the left lateral case and the pre-excited ECG. So this helped a lot to take the diagnosis for this ECG, and this was the diagnosis of the indexed case. That is, it was the pre-excited atrial fibrillation, as because there was no P wave, irregular QRS, and the hallmark of diagnosis of such cases is that QRS irregularity both in duration and amplitude. These two are the hallmark of diagnosis of some cases. So actually we diagnosed this case as the pre-excited atrial fibrillation. This is not an uncommon situation, as because nearly 30% symptomatic WPW syndrome may have atrial fibrillation in their lifetime, and this atrial fibrillation may be the first presentation in asymptomatic WPW, and the greater the number of the incidence of the AVRT in a case, in an index case, there is a greater risk of the atrial fibrillation. So this is not an uncommon findings for a physician and for a patient who has got the WPW syndrome. And this is very much important for the patient and the physician, as because if we miss the diagnosis, if we fail to treat the patient, there will be penalty of life, as because there is risk of the sudden death, as because sometimes this atrial fibrillation may be equivalent to the ventricular fibrillation, and particularly in that situation, we can calculate the risk of that patient, as because when there will be RR interval, that is the excited, that is during the tachycardia, this RR interval, you see the RR interval here is shorter than the RR interval here. So this patient, the lower patient, has got the greater risk of sudden death than the upper one. And that is the RR interval less than 6, that is the less than 240 milliseconds. So this patient has got the greater risk of the sudden cardiac death, not equally for all patients, but this risk can be calculated. So what is the most important part of this presentation is that what is the treatment in such cases, that is the acute treatment in WPW syndrome. The principle of treatment is, when the patient has got the WPW with SVT, narrow regular QRS tachycardia without atrial fibrillation, our policy is to block the AV nodal pathway, this pathway, we have to block this pathway. And when there will be atrial fibrillation, we have to block this pathway, that is the accessory pathway. So this is the basic principle of treatment in such cases. This is not in all cases. When the patient has got the WP, that is atrial fibrillation in such cases. And we have to have some ideas about the drug selection in these cases, as because the proconamide and the quinine are the drugs that can selectively block the accessory pathways. But unfortunately, these two drugs are not available in our country. And these are the groups of the drug, that is the calcium channel blocker, beta blocker, adenosine, digitalis. These are the groups of the drugs that can block the avinodal pathway. And all these drugs are available. And there are some of the examples of the drugs, amiodarone, sotalol, propofol, flecainide. These four drugs can block both the pathways, that is both the avinodal pathway. So this conception is very much important for taking decision about the treatment of such cases. So what should be the option for treating these cases? Options are whether we shall give the IV verapamil in this case? No, as because it will block this pathway and will cause the faster conduction of this pathway. IV adenosine? No. Amiodarone? This can be the second choice, as because we don't have this group of the drugs, so this can be the second choice, as because this can block both the pathways. DC cardioversion? Yes, when the patient is unstable. So this is one of the example of my own case in my working place. This is the presenting ECG, and the attending doctor give the verapamil before we attend there, and this pre-excited trachea degenerated into the, fortunately, it was in the CCU, and the DC shock was available that can save the life. So this may happen. It happened because the verapamil blocked the normal conduction system. All the atrial fibrillation conducted through the accessory pathway, and atrial fibrillation becomes equivalent to the ventricular fibrillation. That could cause the death of the patient. So this is the situation. So what is the take-home message of this case? Pre-excited atrial fibrillation. We must not miss selection of drugs for treating these cases when the patient is hemodynamically stable. This is the message of this case. So my second case, this is another case. 35 years old male attended emergency department. The patient has got the syncope 3 hours back and fever for 5 days. The patient also gives history of the loss of consciousness 6 times before. No other comorbidity, no family history of the syncope or sudden death. So what is the diagnosis? Finding in this case, you can see please that is the ECG shows the sinus rhythm, heart rate 58 beats per minute. There is ST elevation in V1 and V2, ST elevation V1 and V2. And biphasic T waves. This is the findings, striking findings of this ECG. So obviously the differential diagnosis is acute anteromyocardial infarction, incomplete RBB, early repolarization syndrome, and the Brugada type. These are the differential diagnosis of these cases. So actually, it is not this is not the MI, as because the shape of the ST segment not suggestive of the MI. There is no loss of the ROF. From V1 to V6, there is no loss of the ROA progression, and there is no reciprocal change. So without history, from the ECG, we can say this is unlikely with a myocardial infarction. Then not RBB, as because, although it looks like to sometimes when the typical cases, V1, V2 suggestive of the RBB, but absence of the S-wave, when there is a confusion, we can take the help from the lead 1 and V6. There is no S-wave and the slurring of the S-wave in lead 1 and V6. So RBB is not unlikely. Early repolarization syndrome, this is one of the important differential diagnoses. This is one of the possibilities, as because both the condition has got some similarities. Almost similar pathophysiology of these two cases. There will be some channelopathies, that is the abnormalities of the channel in case of the Brugada syndrome around the right ventricular outflow tract, and that is why this is detected by the V1 and V2. Or sometimes in V3, depending on the outflow tract. But in case of the early repolarization, the same types of the pathology happens in the lateral wall or the inferior wall, and that is the region. In this stage, that is early repolarization, the ECG stages are localized to either in the lateral leads or in the inferior leads. So early repolarization is one of the differential diagnosis, but location of the pathology either in the V1, V2, V3, or the lateral wall or the inferior wall, that helps to differentiate these cases. And there are also some similarities. Both the conditions, maybe the cardiac arrest, maybe the presentation of the first symptom, third and fourth decade is the most critical time for presenting such cases. So early repolarization syndrome is also unlikely, but the presenting case is almost obviously, it was the Brugada syndrome, as because this is the Brugada pattern, that is the ST elevation in V1 and V2, saddle-shaped ST elevation, and this is one of the important findings, that is the 40-degree angle of ST with the ROF. This is the 40 degree of ST segment with the ROF. That is described in the EP Europe 2021 volume. You can, those who are interested, we can go through this presentation. That is the 45-degree angle of the ST segment with this cable. So this is obviously, finally, we conclude that this is a case of the Brugada pattern type of ECG, and this should not be missed, as because ECG is the only diagnostic, this is the ECG-based diagnosis. There is no other test. ECG is the only diagnostic test for this kind of the pathology. And VF is the presenting arrhythmia most of the time, not VT. It is the VF that may be the presenting findings. And dynamic ECG, this is not always present. One ECG may show, the other ECG may not. And very sad is that beta blocker or amiodarone cannot prevent the sudden cardiac death. So this is very much important. We cannot be happy presenting with the beta blocker, that is the amiodarone in these cases. This is very much important. And this is the reason we should not miss these cases. And the presenting case was actually the Brugada type 2. We can see this is the Brugada type 2. This is the V2, V2, V2. This is the type 1, that is a cove shape. Two important findings. That is the shape of the ST segment and inversion of the T wave. ST and T. For classification, we have to know ST and T. ST elevation shape and the T inversion. ST saddle shaped, biphasic T. ST saddle shaped, positive T. This ST and T, these two parameters help to differentiate this type of ECG. Our presenting case falls in this group. That is the type 2 Brugada. Then what should be the treatment option in this case? That is the treatment option in this case, the presenting case. What should be that? These are the actually, what should the attending physician at emergency advise to this patient? Whether he will advise the patient for the ICD, an admission for the ICD, or electrophysiologist for the drug silence test, or reassurance or the genetic test. What should be the options? Actually, ICD no, as because even the patient type 2, and it was expected that the patient during the fever should have the that is the type 2 should be converted into the type 1 and negative family history. So ICD is no. Reassurance, yes, we cannot leave the patient with reassurance alone, as because this is the definitely type 2 Brugada syndrome and the history of the loss of consciousness. We have to give the explanation for the loss of consciousness. And genetic testing, no, as because genetic testing has got only 30% sensitivity and not indicated without the family history. And drug silence, yes, this patient can be sent or advised for the drug silence test. And it was, we did it. Actually, this is the flagrant silence test. This is the baseline ECG before the flagrant, and this is the ECG after the flagrant. There is some ST research that is the conversion of the type 2 to the type 1. So the flagrant silence test was the positive. So what should be the, finally, what should be the suggestion for the patient? We can follow this flow diagram that is suggested by the cardiac electrophysiologist, that is board review and self-assessment, page 325. This is recently published, and this is described, this flow chart, and we have taken from that area. So our patient falls in this area. That is silence with the sodium silencer blocker, and flicker test is positive. So the patient have to follow this pathway, and we will give the final suggestion for this patient. So finally, what is the take-home message for this case? Take-home message that we must not miss peculiar pattern of ECG in V1, V2. We must not miss, and we can take the help of the. There is another case, time is short, I think. This is the 52-year-old lady. Actually attended the emergency department with the central chest pain for about 30 minutes, not associated with the diaphoresis, non-diabetic and non-hypertensive. And finally, we reviewed the cases. This is the non-specific finding in this ECG. This patient stayed at the emergency department for about 1 hour. Troponin result came, showed normal, and the patient was discharged and advised to attend the OPD next morning. But next morning, before attending the consultation, the patient again attended at the emergency with this ECG, and obviously this is the acute MI with the LED to read. Sorry, thank you very much.